Mayo Clinic presents
Emergency Medicine Grand Rounds.
Happy Valentine's Day. Today's release is better tasting and, of course, lower fat and calorie than any box of chocolate that you might eat today. But of course, you can and should enjoy both together. This is, of course, Always on EM, a podcast from Mayo Clinic about emergency medicine, and I am Venk, like vancomycin. I get the joy of hosting this with my work Valentine, Alex Finch. We are excited to bring you our Grand Rounds experience that we all got to enjoy here in Rochester a few months back from a world-class educator and one of the social media leaders that Alex and I truly admire. His name is Brit Long. He is a true legend in our specialty, and it was so fun to spend time with him and his beautiful family when they came to Rochester, and you are in for a true treat today. If you're in the mood and want to show some love, please hit that like button, follow, and comment about our show on whatever platform you prefer. Okay, before we begin the actual recording, a couple notes. The presentation was highly interactive, and as an audience, there were some times when there was silence, which I've taken out so that you as a listener can have a better experience. Also, there is some ribbing that happens between the faculty and the residents related to the annual staff and residents softball game, and you'll hear that in the recording. Okay, let me tell you more about Brit. Brit is a graduate of the Mayo Clinic Alex School of Medicine before completing residency in emergency medicine at the San Antonio Uniformed Services Health Education Consortium. He is a current active duty lieutenant colonel in the U.S. Air Force and is associate professor of emergency medicine in San Antonio, Texas at Brooke Army Medical Center. At Brooke Army, he is the assistant program director for research for the residency, and he has over 500 publications. Seriously, over 500 publications in PubMed attributed to him. It's really an astounding number. In addition, he has published 35 book chapters and hundreds more free open access publications as well. He is someone that Alex and I aspire to be, as he is a true leader in podcasting, serving as editor and host of the incredible EM Docs podcast, and you'll hear him on EM Rap and ER Cast as well. With all of that said, he is a really kind and engaging person to share a meal with, and has a beautiful family who I suspect keep him grounded and also energize his passions. Brit has received so many awards in his still young career. He has received several Teacher of the Year awards at Brooke Army Medical Center, several Air Force commendations, the Mayo Brothers Award for Military Excellence, and even been recognized as EMRA's 25 under 45 for his impact in emergency medicine. Truly, we are grateful for the chance to learn from him. Take it away, Dr. Long.
Thank you, really are too kind. It is an absolute honor to be with you guys today. It's great to be back. I've been back since 2016. A lot has changed. And you're stuck with me for a lecture. It's going to be an interactive lecture. So we're going to be choose your own adventure, high-risk diseases. Up front, because I am active duty, I have no financial disclosures, and the views expressed in this lecture do not reflect the views or opinions of the DoD, Defense Health Agency, U.S. Army, U.S. Air Force, or my hospital. All right, with that, let's get started. So we're going to be talking about some conditions that cause trouble. Trouble in that they're tough to diagnose, and if you miss a diagnosis, it's bad news for patients. And you're probably going to return and hear all of our favorite question. Hey, do you remember that patient you saw? It's happened to all of us. So objectives for this hour. First, we're going to cover a couple cases with a high risk but uncommon disease. At the end of this session, I want you all to be able to explain the presentation, evaluation, and management of the conditions that we cover. Third, I want you to be able to identify the diagnostic and management challenges of these conditions, and then finally create a plan for when to really consider these diagnoses. Some ground rules. All right, an hour is really tough to be talked at. I've sat in your chair, I remember, it stinks. So this is meant to be an interactive session. I have an ED tracker board with 14 different patients. You get to select which patient we talk about. I will present the case to you. We'll talk about some salient points of the presentation, maybe what your next steps would be, what you're thinking about the differential, and then I'll give a 5 to 7 minute overview of that diagnosis, presentation, evaluation, and management, and we'll go back to the ED tracker board. Obviously, we're not going to cover all 14 diseases, but at the end, you'll be given the summary slides, and you'll be given access to 14 different papers that if you're a nerd like myself, you can read up further on. Any questions before we get going? Cool. All right. I want you all to envision yourselves single coverage, solo night shift. You walk in, these are our patients. You don't have to pay attention to the ESI level if you don't want to. Which patient do you guys want to cover first? Anyone? 3. I like it. Oh, and plus, all of these are patients I've seen and potentially made some mistakes on. We'll just leave it at that. So, room 3, 37-year-old male with back pain. Says he's having some fevers, some chills. He's got a history of end-stage renal disease, diabetes. He's having worsening back pain for weeks. Little bit febrile. He's tachycardic. He has diffuse back pain, but otherwise normal neurologic exam. What are you guys concerned about? Epidural abscess. I hear it in multiple places. Great. That was easy. Man, I threw you guys a softball, first one. So, spinal epidural abscess.
That's not a good example for our because they haven't won one of our bracket times.
Oh, man. Oh, it's tough. Ooh, man. Yikes. Yeah, thrown under the bus right away. Wow. Okay, so you guys have to prove yourselves then. He's throwing down the gauntlet here. So spinal epidural abscess, pyogenic infection of epidural space, often involves 3 to 5 different vertebral levels. Now, the mortality rate is 5%, but around 50% of these patients will have a permanent residual deficit, even with appropriate treatment. Now, the problem here is how these patients present. It's often back pain. Think back to your last shift. How many back pain patients do you see? A bunch. So, studies show that around 1 in 300 to 1 in 350 have some sort of spinal emergency. So that means we're potentially missing this diagnosis. The other issue is these patients can present with flu-like symptoms. That makes it even more confusing. So, this is one time where you have to have a cognitive stop point. Middle of flu season. What is your differential for a patient who presents with flu-like symptoms? Yeah, spinal epidural abscess is one of those. Others are myocarditis, toxic shock syndrome, meningitis, and then carbon monoxide toxicity, among like sepsis, septic shock, those kind of things. But in my medical decision-making note, I have a dot phrase that will auto-populate, and it makes me stop and think, hey, do I need to go back and spend some more time in that room? Classic triad for spinal epidural abscess: back pain, fever, neurologic deficit. Like every other classic triad out there, less than 15% of cases will actually have that true triad. So don't rely on that. Instead, you need to be thinking about red flags. The first red flag is, does this patient have episodes of recurrent vascular access? So my 2 cases that I've diagnosed in the past 6 months, not been in injection drug users. That is one big patient population. The other one is end-stage renal disease patients. The other big risk factors are some sort of immunocompromised state. So again, end-stage renal disease patients, they're immunocompromised. End-stage liver disease, poorly controlled diabetics, cancer patients, and then recent spinal instrumentation or surgery. These patients often present with a progression of symptoms. So often we'll start with back pain, maybe some flu-like symptoms. Next stage, they'll start to have radiculopathy as those nerve roots start to be compressed. Then they can have weakness, bowel and bladder involvement, and then paralysis. And unfortunately, once they reach those last 2 stages, those deficits are often permanent. Now, labs can be helpful. I'm not talking about the white blood cell count. It's going to be elevated 68, 70%. You know, lots of pitfalls with white blood cell count. But inflammatory markers, ESR and CRP, can be useful when they're a part of a diagnostic algorithm. Blood cultures, if you're concerned, these will be positive in about 70%. Definitely get them. Now, the test of choice is an MRI of the whole spine with and without contrast. I said whole spine for a reason. Your radiologists are going to hate you. It's probably going to require some sort of conversation with them. But about 15% of these patients can have a skip lesion or an area of non-contiguous infection. Patients who are older have symptoms for over 9 to 11 days, and patients who have significant elevated inflammatory markers like an ESR over 90, 95 do have a higher risk of a skip lesion. All right, that was a lot. So we talked about history exam. I kind of hinted at this diagnostic approach. What I use, if I have no risk factors present on my history and exam, I'm done thinking about spinal epidural abscess. That doesn't mean, though, I'm done thinking about other spinal emergencies. Now, if they're moderate risk, that means they have no motor deficits, but they do have some risk factors. That's the patient where I get inflammatory markers on. The ESR or CRP is going to be dependent on your institution. If those are elevated, then I'm going with the MRI. If they're negative, I'm stopping my workup for spinal epidural abscess. Now, if you're concerned they have progressing neurologic deficits, that's the time to pull the trigger on the MRI. All right, treatment. So all of these patients need some sort of spinal surgeon consultation. Who do you guys consult here? Spine? Okay. So at my academic shop, we have 2 different services. They alternate day to day. I guarantee you, even though it's a 50-50% chance, I will choose wrong 95% of the time. Get on the phone with them. Now, all patients will need antibiotics at some point, but not all patients will need surgery. If they're stable, your spinal specialist may want to take them to the OR to get cultures of the affected area. All right, they may want you to hold on antibiotics, just document that. Now, if they're decompensating, they're sick, they have a progressing neurologic deficit, give them the antibiotics. Now, patients who need surgery are those with an abscess, they have involvement of the cervical or thoracic region, or if they have progressing neurologic deficits. Any questions about spinal epidural abscess? Good question. So there have been studies looking at CT. I don't think it's ready for prime time yet because our radiologists haven't had the dedicated training. In centers that do a cone down view of CT with IV contrast, it's actually a really reliable test, but that involves basically a specialty trained neurology radiologist to look at that. So in the community, general radiologists, not ready for prime time. Good question. Anybody else? All right. What case do you guys want to hit on next? 7, one of my favorites. 71-year-old female with altered mental status. So she's 35 degrees Celsius, heart rate's 55, hypotensive, a little bit bradypneic, slow to respond. Glucose is 55. What are you guys thinking? Boom. Softball record just keeps getting better. All right. So this is decompensated hypothyroidism, condition associated with profound thyroid dysfunction. Mortality rates reach 60%. The most common patient population are going to be older women, and then they have a history of hypothyroidism or prior thyroid surgery. Now, hypothyroidism exists along a continuum. At one end, you have the compensated form where they're not going to have any end organ injury or failure. They may have some symptoms, though, from that hypothyroidism. At the other end, you have the decompensated state where they have severe end organ injury and organ failure, and then they have that classic clinical picture, the altered mental status, bradycardia, the hypotension, and hypoglycemia. Now, like every other endocrine emergency, something pushes these patients over the edge into that decompensated state. In this condition, it's most commonly going to be an infection like sepsis. There's others like medication non-adherence, ischemia like stroke, MI, electrolyte abnormalities, environmental exposures. Now, mixed edema coma was the previously kind of considered diagnostic term for this. I tend to go away from that because not all patients will have mixed edema. That's that lipopolysaccharide deposition in the extremities. And then not all patients will actually have coma. It's more like this hypoactive delirium state where they have some change in altered mental status. Let's get to the features here. So I think about these patients as low and slow. And because of the thyroid's impact on bodily functions, almost every end organ system is going to be affected. So cardiovascular-wise, bradycardia, hypotension. That hypotension is often refractory to fluids and vasopressors. They can have prolonged QT, pericardial effusions. Pulmonary-wise, they can have pleural effusions, bradypnea, and these patients can be a difficult anatomic airway because they have tongue swelling. GI, they can have nausea, vomiting, constipation, ileus. Renal, they can have an AKI. And hematologic, they actually have increased bleeding tendencies because they have an acquired coagulopathy, and they can have anemia. Labs are going to provide some important clues. So in over 80% of patients, they're going to have a significant elevated TSH and almost an undetectable T4. Hyponatremia is very common. They can have muscle breakdown that causes their CK to elevate. They can have hypoglycemia that's often refractory to glucose repletion. They can have elevation of LFTs. Blood cultures are important to get because, again, the underlying trigger most commonly in these patients is going to be sepsis. EKG, you might see evidence of pericardial effusion. You can see tamponade picture. You're probably going to see prolonged QT, and then imaging. Patients are going to be altered. They're going to be getting a head CT. But your other imaging really needs to be kind of come into what your clinical findings are on your history and exam. So if you have a patient where you're not finding an underlying etiology, I have a low threshold to obtain CT imaging of other body parts, especially the abdomen and pelvis. When should you really be thinking about these patients? So my big things here is if I have a patient where it's that combination of that low and slow type states. If they have hypoglycemia that I keep giving D50, D10 to, and they keep becoming hypoglycemic. If they're hypotensive and they're refractory to fluids and vasopressors. The next one is if they have the history of thyroid disease, some thyroidectomy, and then they have that combination of laboratory abnormalities that I mentioned. Let's move to treatment. So first thing, find and treat the underlying etiology. Antibiotics, definitely hit them with broad spectrum antibiotics. What's your sepsis cocktail here, or do you have one in terms of like broad spectrum coverage, no known source? Are you piperacillin tazobactam fans or cefepime fans? Cefepime? Yes, I like that answer. That's perfect. All right, perfect. So don't hold back on the antibiotics for these patients. Provide fluids, vasopressors, just be ready when they start to become refractory to those vasopressors. And your next medication would be stress dose steroids. 100 milligrams of IV hydrocortisone, preferably before thyroid repletion. There is some dogma that you potentially can cause adrenal insufficiency that's not backed up by great data, but that's what the guidelines recommend. The next thing is provide thyroid hormone replacement. We're going to touch on that in a minute. And then finally, supportive care, passive rewarming. All right, so thyroid hormone replacement. The guidelines recommend anywhere between 200 to 400 micrograms of IV T4. Now, if you're working at a center where you don't have TSH or T4, that is a fair number of hospitals around the US, you're concerned about the clinical picture, give them that bolus. The normal circulating dose of thyroid hormone is around 1,000 micrograms. 200 to 400 is probably not going to hurt them. Now, these guidelines also support IV T3. The dose for that is 5 to 20 micrograms. When I start to reach for that is if I have a patient who has that refractory shock picture, I've given them the T4, the steroids, I've given them fluids, vasopressors, they're still not responding, or that patient who's intubated. That's the time when I'm reaching for that IV T3. Any questions about decompensated hypothyroidism? Any cool cases anyone seen? Norepinephrine is the first thing I reach for. And then I will do ultrasounds. I get made fun of at my community shop because I'm like the one person who still uses ultrasound there. I work with a lot of providers who've been a little bit in their time a little longer. We have one sauna site for 25 beds. It's an older sauna site, but this is the time I will pull out ultrasound, and if they have good squeeze, then maybe I'll do like vasopressin. Yeah. But once I start reaching for that second vasopressor, or I have that norepinephrine turned up to 20 to 25 mics per minute, then I start thinking about, am I missing something here? Yeah.
When you see hypotension, bradycardia, I think it's through your nephrectomy.
Yeah, good question. So the first thing that's going to come up is this condition. But then you also have to think about, you guys are in a completely different type of climate than I'm in. So you obviously have to be thinking about hypothermia. That's a big one. Now, in San Antonio, if it rains and it reaches 40 degrees, we actually get a lot of cases of hypothermia because our shelters are not built to deal with those type of patients. Sepsis can also present just like this, especially in older people. The more I practice, the more I'm humbled by how patients present with sepsis. Adrenal insufficiency is another big one. Yeah. Good question. So it depends on where I work and what I have available. I'm a big fan of rocuronium and ketamine. I'm also okay with etomidate. There's a lot of controversy in etomidate with adrenal insufficiency. I'm still a big fan of rocuronium and ketamine for most of my patients. That's probably what I'm gonna reach for. Yeah. Yeah, and you can actually give it orally by like an NG tube. It's just the peripheral conversion of IV T4 actually takes a while, or any form of T4 takes a while. It actually takes hours within the body. So that's when I'm reaching for the IV T3, yeah. And that's probably gonna take a while for pharmacy too. All great questions. Anyone else? All right, next patient. All of these are my favorites. I can't keep saying they're my favorites. All right, this was a near miss of mine. So 35-year-old female with headache and vision changes, subjective vision changes. She has a history of PE, somehow she's on OCPs, somewhat hypertensive, the rest of her vital signs not really remarkable. Glucose is normal. She has a completely normal neurologic exam. And I'll throw in, this is her second visit for her headache. All right, what are you guys thinking about? Pretty big differential. And okay, they just scored a run. That's a big one. Boom. Cerebral venous thrombosis. Nice. All right, so this is a clot within the venous system that reduces venous outflow, leads to increased ICP, vasogenic edema, and then cytotoxic edema in the end stages. This is the venous system of the brain. Most common site affected is superior sagittal sinus, and that's followed by the transverse or lateral sinus. Now, the tricky thing is how these patients present. This accounts for about 1% of strokes overall, but over 2/3 of patients are going to be women, and it's most commonly in the ages between 30 to 40, not your normal stroke population. Less than 10% of cases occur in those over age 60, and most of those cases are associated with some sort of malignancy. Over 85-90% of patients will have at least one sort of clotting risk factor, and over 50% will have at least two. So history is really important for these patients. A couple different flavors in how these patients present. The most common symptom by far is headache. It's typically this dull, gradually worsening headache. They can present though with that thunderclap type picture. The next stage is going to be some sort of neurologic deficit, and that's about 40% of these patients. It's often some sort of motor deficit or vision change. Sensory changes are a little bit less common. 40% can also have a seizure. The final way these patients can present with severe elevations in ICP is altered mental status with encephalopathy. So again, 4 big ways these patients present. Altered mental status is the end stage. Most common one is going to be a worsening headache, and then focal deficits and seizures. You see patients with headache all the time. We are experts at risk stratifying and figuring out who do I really need to work up. So what I think about in terms of working these patients up for cerebral venous thrombosis is a patient with headache and they have some sort of neurologic deficit or vision changes. If they're a young patient with stroke-like symptoms, the other thing I think about that is cervical vessel dissection. If you have a stroke patient with seizure, you have unexplained increases in ICP, you have a negative head CT, but a persistent severe headache and they have multiple ED visits. And the final one is if they have a head CT and you're finding multiple hemorrhages in a non-arterial distribution. That's because the venous system does not follow your normal arterial distribution. Normally, when we think about a neurologic condition, especially the brain, headache, we'd reach for non-contrast head CT. That's gonna be normal in about 30 to 60% of these patients. You might get lucky, you might see this, which is the dense triangle sign. You can also see the cord sign, which is the actual clot. A good first-line test is going to be a CT venogram. That has a sensitivity and specificity both around like 90 to 95%. MRV is the other imaging test. This is the test to go to if that patient is altered or you're concerned about that encephalopathy picture. This is potentially a time-sensitive diagnosis. These patients could be seizing, or if they have neurologic deficits and you're concerned about herniation, increased ICP, you need to reduce that ICP. So raise the head of the bed, give them some sort of hyperosmotic fluid, and then touch base with your neurosurgeons. There have been studies looking at therapeutic lumbar puncture, ventricular draining. Those have not demonstrated improved clinical outcomes. Excuse me. Your neurosurgeon may end up taking them for decompressive hemicraniectomy. The remainder of your treatment, sorry, my girls gave me a nice little cold that I'm just getting over, is anticoagulation. And that's even in the setting of intracerebral hemorrhage. So if they have intracerebral hemorrhage, that's not a contraindication to anticoagulation for these patients. Your medication of choice is going to be low molecular weight heparin. That demonstrates improved clinical outcomes and reduced risk of mortality when compared to unfractionated heparin. End stage, they're probably gonna be placed on a DOAC or warfarin. There is a meta-analysis looking at warfarin versus DOACs, similar mortality, similar rates of recanalization, rethrombosis, and bleeding. Any questions about cerebral venous thrombosis? Anyone see any interesting cases? Yeah? How'd they present? Gotcha. Yeah, this lady I got pretty lucky on. She was a bounce back, had a negative head CT up front. I was just thinking like, should I do the CT venogram? And I was trying to convince myself not to too much. So I ended up just doing it and found it. It means I probably missed it multiple times, unfortunately. Okay, what patient next? 10, I heard. This was an interesting one because I had a great interaction with a specialist. All right, 22-year-old female, pelvic pain, vaginal bleeding. Comes in by EMS, hypotensive, tachycardic, tachypneic. She has severe abdominal tenderness. Next steps, conditions that you're worried about. What do you think? Ectopic? Yeah, ectopic. Okay, nice, good. Ectopic pregnancy. So when you look overall, about 2% of pregnancies, but in ED populations of those with concerning symptoms, that number is closer to around 16%. So it's any pregnancy that implants outside of the uterus. Most common site is going to be the fallopian tubes. And this is still the primary cause of mortality in the first trimester. So something we can't miss. There are a lot of pitfalls when it comes to ectopic pregnancy. One of them is risk factors. So the most common risk factors are going to be a prior ectopic, some sort of tubal abnormality like a tubal surgery, tubal ligation, PID, TOA, but about half of patients will have no identifiable risk factor. The exam and also history is variable. So the triad is abdominal or pelvic pain, vaginal bleeding, and missed menses. So vaginal bleeding is anywhere between 50 to 80% of patients. Missed menses is around 80%, and then abdominal pain is going to be present in 80 to 90%. Up to about a quarter of patients will not have that triad, and 10% will have only like real mild or minimal symptoms. These patients can also present in shock with severe hypotension. Now they can be tachycardic, or they may be bradycardic because of excess vagal stimulation from that free fluid within their abdomen. So big takeaway here is if you have a female patient with any evidence of pelvic pain, vaginal bleeding, they're hypotensive, pull in your bedside ultrasound and perform the FAST exam. If you find free fluid and there's no history of trauma, that is a ruptured ectopic pregnancy until proven otherwise. Now, much of our testing is geared on the pregnancy tests, whether it's positive or negative. So urine tests will pick up quantitative levels around 20. There are some assays that can pick it up around 10. If you're concerned about ectopic pregnancy, get the quantitative level. Now, once you get that quantitative level and it's positive, you can't use that specific number to rule out ectopic pregnancy, and that number does not predict the risk of rupture. The most recent evidence on this was published in Western Journal of Emergency Medicine, May 2024. They looked at over 500 patients with ectopic pregnancy. Over 50% had a quantitative level less than 1,500. Over 40% of patients with a rupture had a quantitative level less than 1,500. And you're backed up by ACEP here. So recommendation number one, get the ultrasound, and that is the imaging modality of choice. And it doesn't matter what your quantitative level is. Don't use that quantitative level to exclude diagnosis of an ectopic pregnancy and obtain specialty consultation. That seems pretty straightforward. You're looking for, on ultrasound, some sort of adnexal mass. Hopefully, if it is an ectopic pregnancy, it's a clear-cut, either yolk sac or gestational sac. Lots of different treatment options. If they're sick, they're critically ill, they need blood products, resuscitation, and they'll need operative intervention. Now, many patients are still going to need operative intervention even if they're stable. Some patients might be candidates for methotrexate. Those patients are stable, they can follow up, they have no evidence of renal or liver impairment, and they have a mass that's less than 3 to 4 centimeters with no fetal heartbeat. The key thing is if they get methotrexate and they come back, perform labs and an ultrasound, okay? If they come back with pain, vaginal bleeding, there is around a 4 to 18% risk of tubal rupture, and those patients need operative intervention. Finally, if that patient has a quantitative level less than the discriminatory zone, and that's the first time I've mentioned that number, they need follow-up with OBGYN clinicians, especially if you do not see anything on your ultrasounds, okay? Because they need a repeat quantitative level and they need an ultrasound. Any questions about ectopic pregnancy? If not, I'll talk about my case. So it was this lady. She came in, I performed a bedside fast. It's positive. We got the quantitative level. I'd already called OB and they said, well, talk to me when you have a quantitative level. It was 300. She said, I've been practicing 25 years. Can't be a ruptured ectopic. Like, can you just please come see the patient? I have no other thing that this could be. And she's like, oh, it's probably just a rupture. I'm like, she's still hypotensive and this is her second unit of whole blood. Can you please come down? So they took her and she did end up having a ruptured ectopic pregnancy. Thankfully, she did well and survived.
Can I make a plug? Always on EM podcast this month. We sat down with one of our OB/GYN docs through this in great detail as well.
Yeah, as you can probably see, I'm very simple. I like things straightforward because EM is very complex. I need something really easy to follow. All right, next case.
About 14.
Yeah. Okay, 53-year-old male with several days of watery diarrhea. He has a history of non-small cell lung cancer, and he's on Pembro or Keytruda. You guys see immune checkpoint inhibitors, right? Yeah, great. So looks okay. He's a little bit tachycardic, but he appears fatigued, tired. He's got kind of diffuse abdominal tenderness, but no evidence of peritonitis. What are you guys thinking? Perfect, man. Rattled off right away. The residents at my place really struggled with this because immune checkpoint inhibitors are just becoming a big thing at my center. They haven't seen too many issues. So, as you all know, T cells, integral role in the immune system. They identify, get rid of damaged cells that could be from infection or malignancy. Now, there are several cancers like lung cancer, melanoma, renal cell carcinoma, even lymphoma, that can trigger these immune checkpoints and basically kind of down-regulate how much T cells are active. Immune checkpoint inhibitors are these monoclonal antibodies that bind to T cells and basically inhibit the inhibitor. So they kind of reactivate those T cells to function. There are multiple different sites, not super important for us. What's important for us is knowing what your center has and what the patient is on. And this is why your history is really, really important. The last time I saw, actually, it was this patient. He had really no idea what he was on. He said, I'm just on some special cancer drug. His wife arrived 30 minutes later and provided the key information for us. Now, there is a grading scale from the National Cancer Institute. This is from 1 to 5. 1, real mild, moderate symptoms, and it goes all the way 5, which is death. Now, the vast majority of patients, over 90%, will have grade 1 or 2 adverse events. And most of these adverse events will occur within the 6 months of treatment initiation. The treatment is also based on the grade. All right, so if they're grade 1, they can continue. Grade 2 and higher, they need to stop, and then they're started on steroids. There are some other intricacies based on the organ system affected. So we had touched on colitis, which is what was mentioned. Around 30% of patients on an immune checkpoint inhibitor can experience this. It's often some dull, diffuse abdominal pain, some cramping, and then some diarrhea. Now, if they're febrile, hypotensive, over 7 stools per day, that's that grade 3, grade 4. Now, at the National Cancer Institute recommends stool studies, and they also, in those severe patients, recommend imaging with CT to evaluate the degree of inflammation and also look for other complications. And like I said, grade 2 higher, you're gonna need steroids. Pulmonary complications. So this is actually more common than people realize. It's about 20% of patients. The big one is pneumonitis. That's the most common cause of death related to an immune adverse event. These patients can present with a variety of symptoms. It often can look like PE until you look at their history. So pleuritic chest pain. It's often a non-productive cough. They can have shortness of breath, hypoxemia. X-ray, unfortunately, has a sensitivity around 75%. So most guidelines recommend obtaining CT imaging to evaluate the degree of inflammation and then also look for other complications like a PE. These patients will need steroids, they might need airway support, and then if they have grade 2 or higher, that's the patient who has over 50% of lung involvement and they're hypoxic. They need antibiotics with the steroids. Also, key takeaway here is that if they're on steroids for over 12 weeks and they come in with this, you need to give them coverage for pneumocystis with trimethoprim sulfamethoxazole. Dermatologic issues, 50% of patients. It's usually kind of mild, maybe some pruritus, vitiligo, lichenoid reaction, but DRESS syndrome, SJS/TEN can occur. Endocrine, about 17% of patients. That's more commonly going to be like hypophysitis, which is pituitary gland inflammation. They can have hypothyroidism, hyperthyroidism, diabetes, and unfortunately, a lot of times the first time they present with diabetes, they'll be in DKA. Adrenal insufficiency is thankfully very rare. Renal is the next big one. It's about 30% of patients. The most common renal issue that we're going to see is interstitial nephritis. They're going to need renal ultrasounds, urine studies, serum studies. They may even need biopsy and then renal consultation. Hepatitis affects about 30%. It's usually just some mild elevation in LFTs, but they can present with that end-stage liver type picture with fever, jaundice, severe abdominal pain, and hypotension. The important thing, if you see elevations in their LFTs, are to exclude other causes of hepatitis for these patients. Neurologic. So most patients will actually have some sort of sleep issues, headache, they can have depressed mood. But the two big ones you need to think about here are myasthenia gravis and non-infectious encephalitis. Those both have mortality rates that reach around 20% if it's related to one of these conditions. Cardiac. All right, this is less than 5% of patients. The big one to think about is myocarditis. So if you see troponin elevation, they're tachycardic, that actually has a mortality rate that reaches upwards of 50%. Pretty significant. And the final one is hematologic. Big ones is going to be like hemolytic anemia or thrombocytopenia. There's really no percentage for that. It's very rare based on case reports right now. The final one I want to make you guys aware of is cytokine release syndrome. Has anyone ever seen cytokine release syndrome? Yeah. Do you do CAR T cell therapies for? Okay. So this is what the normal association is CAR T cell therapy, but there have been documented associations with several immune checkpoint inhibitors. So these patients are going to look like sepsis, septic shock, fevers, hypotension, myalgias, nausea, vomiting. That's because every organ system is affected from those ramped up T cells and massive cytokine release. Now there is a grading system. The big one that I want you to think about is every patient has to have fever to make this diagnosis. They're going to be hypotension, potentially hypoxic, and then treatment, you're going to be giving these patients antibiotics, you're going to be resuscitating, and then tocilizumab and steroids are the key treatments. Thank you, picked the really long one.
How do you differentiate?
There's really no way in the ED. So the other things, I'm glad you talked about that, it's sepsis, but then the other thing is tumor lysis syndrome in these patients. So you have to think about PE, and then CHF is going to present very similarly to this.
We had a cytokine release syndrome maybe a month ago. There was on viral therapy.
Oh man.
It looked great for an hour or two after, was discharged in 3 hours. Amazing thing was after resuscitating, he was discharged around. Like that was the first time that I had
Wow.
for me.
Yeah, great case.
Do you get steroids?
We did not.
Yeah, I would reach out because the recommended first-line medication other than the antibiotics and the fluids are the tocilizumab, which I have no access to. I don't know of any center that can get that in the ED, so it's going to be usually like an ICU type medication, yeah, with special approval from someone. All right. Next case. What do you guys want to hit on? 42-year-old male with headache, neck pain. He says he feels unsteady when he's walking around. This is his second ED visit. Probably see a pattern here with bounce backs. For some reason, I feel a lot of bounce backs. Trouble walking, a little bit hypertensive, neurologic exam, otherwise normal, but he is truly ataxic when you get him up and walk him around. What are you guys thinking about? Differential, next steps, vertebral dissection. Good, nice. So this is a spontaneous cervical artery dissection. Basically a tear or injury of the cervical vessels, actually kind of like an aortic dissection, just a different blood vessel that's involved. Now the problem is that can lead to cerebral ischemia and hypoperfusion. In fact, up to 25% of strokes in patients less than 45 years are due to this disease. So the two big vessels that we're concerned about are the carotid and the vertebral. Now, around 20% of these patients can actually have dissections or areas that are affected in the same blood vessel. So multiple areas could be affected. And the dissection can also extend intracranially and lead to a subarachnoid hemorrhage. We don't have a complete understanding of the pathophysiology. There's probably some sort of minor inciting event, even though spontaneous is in the name. And I'm not talking about like roller coaster rides or chiropractic manipulation, which is like the classic association. But there are multiple case reports of people recalling like they yawned strangely, or they were in a yoga class or dance class, painting. So basically activities of daily living. There's often some sort of underlying risk factors, typically like a connective tissue disorder like fibromuscular dysplasia. Migraine headaches and hypertension are also risk factors. Presentation comes in two different forms. So the first one is some sort of compression of local structures that causes severe pain. The other one is ischemia. So the compression symptoms, unilateral head pain, face pain, neck pain, and that could be anterior or posterior. Neurologic deficit is actually more common than you think. Around 60% of patients can present with a neurologic deficit. Partial Horner syndrome, that's ptosis, meiosis, but no anhidrosis, is present in less than a third. And that's actually the classic triad, is that unilateral pain, a contralateral neurologic issue, and then that partial Horner syndrome. But again, classic means it's not common, so less than 10%. Ultimately, the anatomy affects the presentation. So if you have a patient with carotid involvement, they're going to have that anterior pain, they might have contralateral motor or sensory changes. If it's a posterior involvement like the vertebral dissection, then they're going to present with that posterior circulation ischemia type picture, and they're going to present with that posterior type pain. So again, you see a lot of patients with head pain, face pain, neck pain. When should you really think about this? So the big one is if they have that pain and it's a stroke patient, especially if they're younger, like that cerebral venous thrombosis type picture. If they have recent inciting events, they have some sort of history with connective tissue disorder, or they're a bounce back. Every bounce back patient, you need to expand that differential. Imaging is going to be a CTA of the head and neck, and you're looking for that dissection, either flap, and then you're also looking for any intracranial involvement. MRA is potentially another option. Do you guys have MRA capabilities? Yeah, not really. Okay, so CTA would be your first bet. There have been studies looking at ultrasounds. Unfortunately, the sensitivity ranges anywhere between 20 to 90%. That's because of the vessels that are involved. Your specialist may use that to evaluate the progression of the dissection, but I caution its use as a first-line diagnostic modality. Now, treatment is time sensitive because these patients might actually be a thrombolytic candidate. It's crazy. They're a dissection patient who could receive thrombolytics. So those patients have to have a neurologic deficit, present within 4.5 hours, no involvement of the intracranial vasculature, no involvement of the aorta, and no head bleed. Before you push thrombolytics, I would involve your specialist though. This is a very big decision for these patients. If they're hypertensive, they may require blood pressure control. You do want to avoid hypotension to reduce that risk of cerebral hypoperfusion. And really the big treatment here for these patients is going to be some sort of antiplatelet or anticoagulation therapy. That reduces the risk of stroke from over 60% to less than 4%. Big change there. There have been 2 recent meta-analyses looking at this. The first one was published in Stroke just this year, June 2024. They included 11 studies. 2 of those were RCTs. They found reduced risk of recurrent stroke with anticoagulation, but higher risk of bleeding with the anticoagulation. The second meta-analysis looked at only those 2 RCTs, that was TREAT, CAD, and CADIS. They found a trend towards reduction in recurrent risk of stroke and higher risk of bleeding with the anticoagulation. Any questions, cool cases that you guys have seen? Nice. Yeah, wow. Good case. Tricky too.
What's the current therapy that you're getting in your shop here? We're primarily
So the trouble with the studies in both those meta-analyses is they were mono antiplatelet therapy, which we're not really using for TIAs. So our center, it's very specialist dependent. It's based on the neurology attending. We don't have a dedicated protocol. It's 50-50, I would say. And they really base it on like other indications or other risk factors. If they feel the patient is a higher risk of stroke, they'll go for the anticoagulation. If they feel it's maybe lower, they have another indication for antiplatelet therapy, they'll just put them on antiplatelets. It's usually clopidogrel for our patients.
One of our retired colleagues said this had to be memorable for us.
Oh, wow.
Are there any candidates like young patients that
Yeah, good question. Yeah, surgical options do include like stenting over the site. So our center, we involve our neurosurgeons, vascular surgeons, and our neurologists. It's like a team venture. So as soon as we have the diagnosis, we just talk to them. At my community shop where I don't have residents, I basically call our transfer center, who has a care coordinator, and I speak immediately with the vascular surgeon, and they almost always ask for antiplatelet therapy and then to ship them. And I typically like to follow them. Sometimes they do stenting, sometimes they don't. I haven't figured out a pattern, but again, I've only seen this 3 times, and all of those were in my community shop. Yeah.
they all get it especially?
They all got admitted to the specialty center that I transferred them to. Yeah, they didn't send anyone home. Yeah.
I feel like higher diseases that we see out of
Yeah, and I know I've missed a couple of these because I've been notified I've missed them. You're going to see head pain, face pain, tooth pain is a way these patients can present. It's just, I almost think the standard of care is to miss these on the initial presentation if they don't have those neurologic deficits.
We see enough that, for me, I always take pause to make sure that I'm not closing until
Yes.
to the symptom because it may be an incidental sign.
That's a good point. Think we have time for one more? Okay. Oh, perfect. What do you guys think? All right, 27-year-old female. She has rash, nausea, diarrhea, myalgias, malaise. She looks pretty sick. She's hypotensive, tachycardic, febrile. She has this diffuse rash. Check some labs, elevated white blood cell count, an acute kidney injury. She has abnormal coags. Great point. What do you guys think? Very non-specific. It's probably toxic shock. Oh man, hit it, beautiful. So toxic shock syndrome, bacterial infection associated with release of these toxins that function as superantigens. The mortality rate reaches around 80%. Now this is often missed because it's a non-specific presentation. I mentioned those superantigens. So I'm not gonna nerd out too much. Those are proteins that activate T cells, release cytokines, and organ injury. That's the easiest way to think about it. The classic presentation is fever, nausea, vomiting, diarrhea, hypotension, and this diffuse rash that looks like a sunburn. That rash, though, can be transient and it can be intermittent, very subtle. And really, these patients present along a clinical spectrum. At one end, you do have those toxin-mediated symptoms. At the other end, you have the local site of infection. And most patients actually present somewhere in the middle. There are 2 big strains, staph and strep. Each of them have their differences. So staph, usually it's going to be present in those less than 40, lots of different causes, post-burns, post-surgery, some sort of soft tissue infection, menstrual-related causes, postpartum state. Most of these patients present with that toxin-mediated type picture. So flu-like symptoms, erythema, they can have that nausea, vomiting, diarrhea, and then strawberry tongue. These strep patients will present a little bit differently. This is actually more common, and it has a higher mortality rate. So they'll present with flu-like symptoms plus a local site of infection, so cellulitis, pharyngitis, pneumonia. Pregnant patients are at significantly elevated risk of the streptococcal form, over 20-fold increased risk. And to make necrotizing fasciitis even more fun, around 20 to 50% of cases of necrotizing fasciitis caused by strep are going to be associated with toxin TSSS. So labs. White blood cell count, nonspecific, is going to be elevated. You can find anemia, thrombocytosis. You're going to find hyponatremia. And interestingly, an elevated serum creatinine or AKI often precedes any episodes of hypotension. Coagulation tests can be abnormal. These patients can be in DIC, and they can have elevated liver function tests. Blood cultures are a little bit interesting. Less than 5% of the staph patients will have positive blood cultures, and then around 60% of the streptococcal patients will have positive blood cultures. There are a set of criteria that you might know about from the CDC. They include clinical and laboratory criteria. So the staph form, fever, rash, desquamation, hypotension, and then multi-organ failure. I have an asterisk next to desquamation because that often isn't occurring until 1 to 3 weeks after the initial onset of symptoms. The streptococcal one will have hypotension and multi-organ failure. And then you add on labs. There are numerous problems with this criteria. The first big one is that they were never designed for everyday clinical use. They were only designed for research purposes. The second thing is there's been no high quality validation of these criteria. And finally, by the time these patients meet the full criteria, it's often too late and you've missed the boat. So the key here is to have clinical suspicion. People throw that term around. So what do I mean by that? So if you have a patient with severe systemic illness, they have a diffuse red rash, it's a young patient, they have a viral-like syndrome, but they're hypotensive, they look ill, it's a focal infection where there's pain out of proportion to exam, especially in an extremity. They have a severe group A strep infection that looks worse than what you would expect, and they have vital signs that are out of proportion to the degree of infection. If that's the case, begin treatment. So first is going to be source control. If you have a drainable source of infection like an abscess, drain the abscess. Hit the patient with antibiotics, something that's going to cover staph and strep, but then also inhibit toxins. Your big antibiotics there are going to be clindamycin or linezolid. There is some evidence that suggests the combination of clindamycin and linezolid may be better than either alone. These patients are going to need extensive IV resuscitation. They might need vasopressors, IV hydrocortisone. They're going to need the ICU. There is some studies looking at IVIG. The retrospective observational data suggests maybe some improvement in clinical outcomes, maybe a reduction in mortality, but the randomized data don't show a true clinical benefit. I'd leave that to your intensivist. Now, lots of pitfalls with this disease. The first one is just not having it on your radar, just failing to consider it. Second one is dismissing the patient's symptoms. It's just another patient with viral infection. The third one is relying on that presence of that classic rash or other things that we associate with toxic shock syndrome. The next one is relying on those formal CDC criteria. And finally, failing to rapidly resuscitate and manage these patients. So this was one patient I saw during my third year. I just thought it was nothing. I had started resuscitation, had given antibiotics, and she just was not improving. And then I talked to the intensivist, and like, why didn't you think about toxic shock syndrome and add clindamycin? I'm like, oh, good thought, my bad. The other patient that I saw about a year ago actually had a new tattoo that was red and severely painful. He was hypotensive, tachycardic, had like a 22 white count. And I'm thinking, this is probably toxic shock syndrome. I learned my lesson. So I hit them with clindamycin, Vanc, I hit him with piperacillin, tazobactam, and I called the intensivist, and it was like, he looks great. Why does he need to come to the ICU? Well, I know he looks great now, thank you. But he has toxic shock syndrome. He doesn't meet any of these criteria. And then we had a long conversation about the criteria. Thankfully, he took them. I'm very grateful he did because around 2 a.m. he decompensated and they needed to put on a second vasopressor. I hate to see what would happen if you had been put on the floor. Any questions about toxic shock syndrome or interesting cases that people have seen?
This is another one where always.
Oh, yeah, absolutely. All right, we are. Yeah, absolutely. All right, so these are all the conditions that I had slides on. You will get all the summary slides. You'll get a bunch of review articles if you're interested. I am more than happy to take any questions. And again, I apologize about my voice going almost like pubertal there for a second.
If you have questions, go ahead and raise your hand or voice them, and online you can do the same. Also, Sue put a link for feedback on the Zoom chat, and if you want them in the room, do we have the QR code on the screen? Perfect. Okay, great. I know Brit would really appreciate any feedback on his talk. That would be great. So, please. Anyway.
I have a question. So, thanks. Brit, you are right now about 8 years into your career, 7-8 years into your career, highly accomplished and in an area that is, I would describe as a knowledge translator. You like pull knowledge together, you put it out in a way that, people are able to consume and enjoy. How did you, take off on this path? Where did it come from? Just for the residents in the room who are thinking about their lives and careers.
Great question. So Ben is nicely saying I'm a big nerd, because that's what I am. When I was a second-year resident, I had seen some conditions, and I'm like, man, I'm doing all this reading. I'm not seeing good EM literature on it. And so I decided, I need to know more. And I started writing. And by writing, I found that I really got to know the topic real well. And then I decided, hey, there's no publication on this, so why don't we publish something in the EM literature on this, so it helps community docs, academic docs, no matter what setting, no matter what clinical level they are, to disseminate that knowledge. So basically now what I do is I do a lot of literature reviews. I really do almost no true research because the IRB where I work is a little bit painful. But I take stuff that's not really published in the EM literature, and I look at other specialties, what they've published on it, and I try and condense it into one area or one paper for emergency clinicians. Yeah, great question. Cool.
Britt, I'm curious, when you're thinking about a talk that you wish you could hear, what would you like to hear somebody talk on?
Oh, man. Actually, this goes back to you guys. So when Dr. Sandipur was walking me through the department yesterday, he was talking about all of these cool nerve blocks that you guys do. And I was like, what? What kind of nerve block is that? So that's what I would like, is more instruction on nerve blocks and actually also TEE. We do not use that anywhere in San Antonio. And my echo skills, our ultrasound folks at my academic shop make fun of me all the time because it's basically yes, no, and do they have B-lines or pericardial effusion. That's the extent of my ultrasound skills. And that's going above what most community docs have right now. So ultrasound is always good, and any nerve block stuff is good. We are doing fascia iliaca in the community, but everything else, not so much.
What Dr. Long is saying is if Dr. True and Dr.
Yes, absolutely. I was very impressed, very impressed. They've done a great job with your guys' education.
Well, okay. Yeah, go ahead, Moses.
Selfishly, being a fellow military member, any thoughts, wisdom for folks who might be interested in military medicine?
Yeah. So the military can offer really cool, unique attributes. You'll work with some crazy people that you never thought you'd kind of step next to. So my first deployment, I went to Bagram, Afghanistan. We were super busy. I was fresh out of residency. And thankfully, our training program is very, very good about kind of making sure that you're ready to run an ER by yourself. And it was solo coverage at night, and then you'd get called in for mass cals. I had 5 mass casualty events. One of those was an IED explosion, amputation here. We intubated, did a thoracotomy, and we ended up giving, during his hospital stay, over 186 or 187 units of blood in total. And he's still alive today. That was back in 2017. And then my second deployment, I went to Iraq and sat on the Iraq-Syrian border, worked with the 101st Airborne, and got to meet a bunch of Green Berets and trained them how to do medical stuff in exchange for internet for our tent. During that time, I also was able to work with a lot of Iraqi nationals in establishing a medical trauma curriculum for them, and they're still using that today. So it's really rewarding. Yeah. So lots of really cool opportunities. If you're interested, just let me know. We can touch base with you guys about it. Yeah. Great question.
That was remarkable. Thank you so much for covering those fantastic cases, Dr. Long. Everyone, thanks for listening to us on this Valentine's Day 2025. We hope you have a wonderful day overall, enjoying the company of your closest people and some wonderful candy. I'm going to certainly enjoy a lot of chocolate. That's my favorite. Don't forget to check out the EM Docs podcast, which features Brit and his entire team. They're obviously amazing. You just enjoyed that firsthand, and you know that you're going to get amazing content from him and his team every time. So don't forget, check it out. Also, show us some love by liking, following, and commenting on our podcast, and come back March 1st for the next chapter of Always on EM. Thank you for listening. The Always on EM podcast.
Emergency Medicine Grand Rounds.